Just start. Right, good evening, everyone. This is my... Thank you. It's my great pleasure to welcome Daniel Rueckert. Daniel Rueckert has come from Munich today, and it's good that he's back in Munich, in Germany, because he had a long career in the UK, and he has been appointed a Humboldt Professor to kind of lure him back to Germany to continue his work here. He actually started his work in Berlin. He started his scientific career in Berlin, but then quite soon afterwards switched to the UK and stayed there for quite a long time, I would say. He made an impressive career. He had been the dean of the computing facilities there in the UK. And then in 2020, he returned to Germany, to Munich, where he is now a professor and is teaching AI in healthcare. If you're actually Googling AI in healthcare, for sure, one of the first names that will come up is Daniel's name. And I'm very honored and very curious to see what he is going to present today. There's some organizational issues that we have to go through. So this is the timeline for today, and the talk is going to be for about 40 minutes. Then there will be a question and answer session for 15 minutes, and afterwards a networking event in the foyer. We will be taking photos. If you are not content with that, or if you don't want your photo to be taken, I would recommend you leave the room and participate online. Because the talk will be recorded, it will be available on YouTube afterwards. And we urge you to subscribe to the newsletter of the AI Institute KI Center of RWTH and to follow us on LinkedIn. With that, everything that had to be said beforehand is now said. And thank you very much for coming and visiting us, Daniel.
Thank you very much for the kind introduction. We just switch the slides and get started. It's a great honor and pleasure to be here and to talk to you about AI and how I see it shaping the future of medicine. Daniel already introduced me very kindly, so I don't really have to say very much about sort of my background. Perhaps just one thing to say, I'm an engineer or computer scientist by training, so not a medic, so I don't feel fully qualified to talk about some of the medical aspects, but hopefully more about the AI aspects. And I wanted to start with a slide which I think you will now see since this year in many talks. Actually, there are two Nobel Prizes this year which have been awarded, which are very strongly linked to the development of AI as a method, but also AI as a tool in science. And there's a lot of debate on whether actually perhaps medicine is a science or perhaps more craftsmanship. But I do think that perhaps the next sort of Nobel Prize, which is going to be based on AI, is perhaps going to come in the field of physiology. At least I think it's a very good candidate because there are a lot of exciting things which AI can do in the space of physiology and medicine. But you will have seen all of this, so I want to dive straight into the applications of AI in medicine, and perhaps again start off with some newspaper headlines. Actually, the one from the left bottom, Der Spiegel, which talks about, I don't know why everybody, when they talk about AI, very easily sort of automatically take a robot as sort of the symbol of that. I mean, obviously very closely related robotics, but not quite the same as AI. But that portrays that AI is going to revolutionize how we deliver healthcare and how medicine is done. You also see that from the other headlines. Now, before sort of you all have this unbridled optimism that AI will save medicine in the future, it's probably also worthwhile to show some headlines which illustrate that actually there's a lot of hype and not everything which has been promised has been delivered. So this is now from a couple of years ago, but I think the key message is still there. This MIT Technology Review article talks about we have developed during the Corona pandemic lots of AI tools which claim to help us with dealing with the pandemic in a better way, and not all of them have delivered. Some do have delivered, but not all of them. If you remember back, there were AI solutions which were advertised, which will detect when you talk whether you have corona, or when you cough that you have corona, and perhaps didn't really quite work as well as it could have. Let me first show you before I sort of delve into a particular application. The application is actually radiology, which I want to sort of go into in a moment. And there's a very simple reason for that, radiology is sort of, if you look at the number of AI solutions which are commercially available, which are used in clinical practice, and Daniel might actually use some of them in his clinical practice. I'm not sure whether you still do a lot of clinical practice, but 75% of all these solutions are in the space of radiology. And for those of you who do pathology, I've sort of grouped radiology, pathology all together. So please don't be offended, but there's actually much less applications in other domains. And I'll come back to that in a moment, but perhaps sort of to start off with what could be the general vision of AI in medicine. And that is that, of course, you have a lot of types of data in medicine. We have imaging, we have a lot of sensor data. Think of an ECG, of an EEG, or your wearable sensors, even your smartwatch. You have a lot of information about the clinical records of the patient. I don't know how it is in Aachen, but unfortunately in Munich, some of the clinical records are still in this form and not completely electronically available. We have a lot of omics data. We have a lot of lifestyle information. And one of the things where I think AI has the most power is really to integrate that information, because in many clinical scenarios, only a clinician will only look at a part of the data. So a radiologist will only look at the imaging data, will typically not directly look at omics data. Of course, if you go to if you, for example, are unfortunate enough to have a cancer and you go to a clinic to get your counseling and diagnosis for this disease, quite often you now have multidisciplinary team meetings where you have specialists from different domains come together and try to integrate all of that information to try to come up with the best possible diagnosis. So clearly diagnosis is one of the key drivers, what we want to do in medicine, but I would argue diagnosis is really only an intermediate step. What you're really caring about is making a prognosis of treatment effect or treatment outcome, right? The diagnosis is just an intermediate stage. So ideally, we would like to make a complete prediction about what is the best possible treatment for given the diagnosis which we have for a particular patient. So that's one very clear pathway for what AI in medicine can do. But there is another one, and that's very much to do with the idea of going into the direction of personalized medicine, where we would like to actually take the population and look at a particular disease and realize actually a disease like dementia is not one single disease, but consists of lots of different types: vascular dementia, Alzheimer's, frontotemporal dementia, and so on. So we might want to really stratify patients into particular subgroups to be able to select the ideal treatment for that particular subgroup. But we might also really go one step further to the vision of personalized medicine, where actually that stratification is not done on subgroups, but actually it's done on the level of the individual patient, so that we have completely customized our treatment, our diagnosis to one individual, and can do the best possible treatment for that individual. So of course, that's what might be very interesting in a clinical scenario if you work in a hospital, for example. But there are also other components which are perhaps more going in the directions of AI for science. In this particular case, AI for biomedical science, where we might want to discover new drugs, new molecules which have a therapeutic effect, or we might want to repurpose drugs which were originally developed for a different purpose, and actually identify whether we can use them perhaps for another application. So just wanted to highlight an article which I found very interesting, just appeared a couple of weeks ago, or in Nature Medicine, on developing this sort of foundation model for drug repurposing, where you take your disease symptoms and you take your contraindications and indications, and you actually have a network which will predict both the likelihood of indication and contraindication. And then you might be able to actually identify new drugs which work for a particular disease and for which they were not originally developed. So I could list many other applications, and I don't really want to go into all of them. Of course, robotic surgery is perhaps one, but also needless to say that a lot of things which we can do with AI is probably less sexy, but is actually very helpful for increasing efficiency of the healthcare service. For example, report generation, automatic documentation, and so on. All of these things are perhaps not really that well known to, or for a patient, less important, but actually for making our healthcare system, these are very important applications. So let me now come to some concrete applications which I want to show you. And then I also want to highlight some of the challenges which we currently have in the AI research area, which we're currently working on. So let me stick for the moment with radiology. And I've sort of drawn this pyramid of potential applications for AI in radiology, starting at the bottom with something which is actually how we generate our imaging data. Can we improve the generation of images, the reconstruction of images? Can we improve the quality of images, and so on? And then as we go through the pyramid, and as I show you some applications towards the top, we end up with the idea that we would like to better do diagnosis and disease prediction. Now, I assume that not all of you have a medical context, so or a medical degree. So if you, for example, think about how we generate images, then what happens typically is we have a scanning device, an MR scanner in this particular case, might also have a CT scanner that makes some measurements. And then we have these question marks which sort of indicate an operation which transforms the signals which we have captured with our scanner into an image. And most of the time, we don't really measure, like in optical sensing, brightness values, but we measure, for example, in the MR setting, frequencies. In the setting of a CT scanner, you might, for example, measure X-ray absorption. And the three question marks which are illustrated here, they are effectively the reconstruction operation, which turns us into something interpretable. So if I do this with an MR scanner, you do something where you measure all the frequencies in your image. This is called the so-called K-space. You apply a Fourier transform to go back to the, the image domain, and you reconstruct that image. Now, one of the problems with this type of measurement is that it's a very slow sequential measurement. I have to collect one frequency after the other, and only after I've captured all the frequencies, I can reconstruct that image. Now, if you lie in a scanner, this is actually my heart, you have to typically hold your breath for the duration of the scanning. And that can be, if it's relatively short, easy for somebody who's reasonably healthy. But if you're a patient, that might be more problematic. So if you want to accelerate this, if you want to acquire the images much faster, what you do is, well, you do the engineering solution, the engineering hack, you just collect less data. And in this particular case, I'm just randomly sampling which frequencies I collect. And then I pretend I can still reconstruct the data, and you get an image which you see here at the bottom. And hopefully you can appreciate that this image looks much poorer than the image at the top. And the reason is very simple. I violated Nyquist's sampling theorem, correct? So I've thrown away data which actually I've not collected data which I actually need, so I can no longer do an artifact-free reconstruction. So from a reconstruction point of view, I can now sort of think about two different ways of reconstructing this image. I can, for example, say, actually, I'm going to reconstruct it into the image domain, and then I'm going to remove the artifacts which come from the undersampling. And I'll show you in a moment how this could be done. But I will also show you in a moment that this has some real drawbacks, and there's a better way of doing this. So let me start first with how do I do this denoising in the image domain? Well, actually, the way we did this a couple of years ago, this is not very new, is to basically have a deep neural network, which is basically mimicking an unrolled optimization scheme. And this neural network has two building blocks. One building block is a denoising operation, which is just a straightforward convolutional neural network. But then you also have these green layers in the middle of this network. And these green layers do something very specific. They actually transform your data back into the case-based domain, into this Fourier representation. And then they perform a data consistency operation. So they make sure that whatever I'm reconstructing is actually consistent with the data I've actually collected. And then I go back into the image domain and I repeat this. And the reason why I keep on repeating this is that's basically how you do standard iterative reconstruction schemes. You basically have a data consistency term, which is this green bit here, and you have a regularization term, which encodes your prior information, and that's a denoising term. So let me show you how this works in practice. So if you want to accelerate your scan by a factor of 6, that's quite a lot of acceleration. That's what you see at the top. You see on the left-hand side how the image would look like if you just reconstruct it without doing anything. In the middle, you see what the deep learning-based reconstruction does. And on the right-hand side, you see a fully sampled reconstruction, which is 6 times slower. And you can see this works pretty well. And at the bottom, you sort of see this for an even more aggressive undersampling scheme. You see that in the original image or in the original undersampled data set, there isn't really much you can recognize. But actually, these reconstruction schemes still work remarkably well. And they do work so well because there's a lot of redundancy in the data, because we're looking at the same object moving over time. So it's a bit like a video sequence where the background always stays fixed and is not really moving, and we're making use of that. Of course, I can do this in a similar way with brain MRI images. If you don't like hearts, you can sort of do this with MR images of the brain, and you can also see that this works pretty well. But I will also show you that you might run into serious problems if you do this. So in this particular case, we trained this network with brain images, and we are forcing it to reconstruct brain images. On this slide, I'll show you what happens if you train your network with images, MR images of the knee, and you're trying to reconstruct brain images. And you see that in the top row, actually, it does a reasonable job, correct? The reconstruction, which you see there in the third column, is actually pretty okay. I don't know, perhaps the expert will say something different, but I would argue it's probably reasonably okay. But actually, when you go to more aggressive undersampling schemes where you have less data, the AI starts to hallucinate, and it generates an image which I think is a bit of a superimposition of a brain image and an image of a knee, because that's what it has been trained on. And it looks perhaps like the patient had an horrific accident where the knee ended up in the brain, but it's pretty unlikely that this would ever happen, correct? So now I think as a radiologist, you immediately spot something went wrong. But perhaps if you see this, you also question whether in the top image there might be also something very subtly wrong. You just don't see it so obviously. So this is one of the problems. If I don't have the right type of training data, which basically the training data, remember, that sort of is used to train my prior about the reconstruction, I do have a problem. So I want to show you, or I showed you how I can do this. I want to now show you a slightly different way of doing this, by not actually going into the image domain, but actually by staying in the case-based domain. And the reason why this works perhaps better is because I actually might be able to get rid of training data altogether. And I might be able to use only data from the patient which I want to reconstruct. So I don't really have this problem of hallucination because I don't really operate in this scenario. So remember that this between case space and the image space is, in a simplified view of the problem, just a linear transformation, a Fourier transformation. So denoising in the image domain is exactly the same as interpolating the missing bits of K-space. Doing exactly the same, but of course, I'm in a completely different representation space on the left-hand side versus on the right-hand side. For example, on the left-hand side, convolutions don't really make sense because I'm already in frequency space, and neighboring frequencies are not necessarily correlated. Let me explain you how you might use, for example, something called a neural implicit function to do this interpolation. And for this, I want to step a bit back and explain you just in a minute or so how this cardiac MR reconstruction works. So what typically happens is you lie in a scanner, somebody attaches ECG leads to your chest, you record your chest ECG, and then the scanner starts scanning and tries to scan as quickly as possible information in this case space. And if you want to be very efficient, you quite often do something which is called a radial acquisition, where you sort of have your sampling not in Cartesian coordinates, but you're sampling in these radial coordinates, lines in this case space. You do this for multiple heartbeats because typically you can't collect enough data in one single heartbeat. And then after you've done perhaps 10 heartbeats, 20 heartbeats, you effectively do something where you reorder all the lines in case space into one standard heartbeat, and then you're using this information from the standard heartbeat to reconstruct frames in your MRI image. And for that, you need to do some binning, which determines what temporal resolution you have, but let's not worry too much about this. So here you're now sampling this case space, and you have some problems which you typically have in this reconstruction. What I want to do is I want to show you an idea of using a self-supervised reconstruction which fills in these missing bits of case space. And this self-supervised reconstruction is based on an idea which people in computer vision came up with a couple of years ago to try to do scene reconstruction. And it uses a implicit neural representation. And I've shown you how an implicit neural representation looks like for a photograph. It simply learns a mapping between coordinates and pixel values. So for example, you can sort of think about this. I take an image, I train this network to predict at every coordinate to output the corresponding RGB value. And you can sort of think about this as a compression of the image into a neural network, right? But it's done for this particular image. If I give you a different image, you would train a new neural network and get a different set of weights for that neural network. But what you have is now you have you have sort of taken a discrete set of pixels and converted it into a continuous representation, because I can now query my network not only at the learned pixel locations, but at any location in space. And this has been done very successfully for images, for 3D shapes, or for audio signals. So we will do the same thing for our MRI signal, where we have sort of a set of sparse samples in this case-based domain kx and ky, but we also have a third dimension, which is the time axis. And we're going to now effectively train a neural network to take these 3D coordinates, kx, ky, and t, and actually train this network to predict what is the value of the k-space at this location. So we're predicting through a forward pass the value of that location, and then we compare it to the actually sampled location, and we compute a loss, which basically optimizes this network to predict this k-space. So once we have done that, we now have an interpolation function for our k-space, and we can now fully sample our k-space by doing an inference pass where we take a Cartesian grid, we plug each coordinate in this Cartesian grid into our neural network, predict our k-space, and then actually we just need to do an inverse Fourier transform and reconstruct the image. And this is only trained on data from the patient from which you have acquired your k-space data. So it no longer uses training data from other subjects or from a database of training subjects. So this is sort of the idea of this entire framework. And I want to show you just very quickly how this works in practice. On the left-hand side, you see a fully sampled acquisition. On the right-hand side, you see what happens if you only collect for 4 heartbeats. So it's a very short breath hold, 4 seconds data with the MR scanner. In the middle, you see 3 competing methods. And of course, we would claim that our method is better than all the competing methods. But you can push this even more aggressively, and you can sort of get this method to even give you a reconstruction with data from 1 single heartbeat. And what you see for the other methods, they now start to break down. Our method also now produces less good qualitatively looking images, but you can still see that there's a heart contracting. If you want to compute something like the ejection fraction, I would argue you probably still get a fairly good estimate of this. So with this, you can actually push this very, very much. So, of course, instead of analyzing images, reconstructing images, we can also analyze images. We can, for example, segment images with neural networks. I don't want to go into the detail of how we do this because I think there is nothing really new what we do here. But I wanted to show you very quickly an application of this. Especially if we sort of try to do this in 3 or 4 dimensions and sort of integrate information in these higher dimensions. And the application I want to show you is based on a project in the UK, which I think is a very interesting project. There's a similar project here in Germany. In the UK, it's called the UK Biobank. They're scanning over 100,000 subjects. They're collecting a whole body MR image of every subject. They're acquiring brain imaging. They're acquiring these cardiac images. But they have for all of these subjects, for the 100,000 subjects, lifestyle information, genetics, and also what happens to them after they have been scanned. So do they develop a disease? In Germany, we have something called the German National Cohort, which does this in a very similar way. It's perhaps a bit smaller and not quite as openly available as a UK data set. But you can now start to take this data set and, for example, run your automated analysis tools on these 100,000 subjects and see whether you can sort of identify potential correlations between these imaging features and other bits of information. So the first thing which we did is sort of develop a tool which basically outputs normative values for a population cohort. For example, here you see some parameters of the heart normalized, for example, for age, but also stratified for sex differences. We know, for example, there are a lot of differences between the anatomy in terms of, for example, size between men and women. So we need, if we, for example, have clinical guidelines, we must take this into account in developing these clinical guidelines. But we can now also give our clinical colleagues or our medical colleagues a tool to basically identify new associations between image-derived information and, for example, lifestyle information. So let's say I want to know, we probably all know that alcohol consumption has an effect on the liver, but does it also have an effect on your cardiovascular system, on the output of your heart, on other parameters? So you can now sort of look at all these correlations in the same way you, for example, do correlation-based analysis for genetics and other factors. So I should point out that these are correlations and not causation. So we cannot identify really whether these are causal links between, for example, lifestyle and some of the phenotypes you see in the images. And sort of this leads me to sort of the final application I wanted to show you in terms of making diagnoses or predictions, and that's an application where you want to predict the survival of patients when they have a particular disease. And I'm going to stay for the moment with the heart because that's what I showed you all along. You can, for example, take structural information from a particular patient here, for example, showing you the left and right ventricle and how they sort of contract. I can even take the motion trajectories of all the different points on the surface of the heart and actually look at, is a heart contracting completely normal? I can take all of that information and I can plug it into, this was actually a fairly simple model at that time, a variational autoencoder, where basically simply take all that information, the shape of the heart, the motion of the heart, compress it into a latent space representation, which is there in the bottleneck of this neural network, but also force this learned representation in the bottleneck layer to be predictive of the survival of the patient. So I wanted to sort of not only compress the information, but compress the information in such a way that I can use it to predict survival of the patients. And in this particular scenario, if you sort of compare what happens in standard clinical practice, if you use standard measures of the heart from an MR scanner, ejection fraction, LV mass, and so on, you get a relatively poor separation of the two patient groups, which have good and bad survival. If you add some of this more comprehensive information, the algorithms start to decide to be much better able to differentiate between those which have poor survival and those which have good survival. So I've shown you lots of sort of positive applications, but I also wanted to highlight some of the open challenges which I think a lot of people are working on. And the first challenge is something which I think you all very well know. It's very nicely illustrated by this picture. If I train my AI model with data from this population cohort, you might realize that this is not going to work particularly well for the real population, correct? So because of course the characteristics of this population on the left don't match the characteristics of your real population. Now, this is not only a problem in AI, but actually it's a problem in medicine in general. And I think we always had to deal with those sort of biases. There's actually a very nice paper from Ziad Obermeyer in Science 2019, where he sort of analyzed, for example, some of the US guidelines for managing patients, and showed very nicely that they are sort of, they very explicitly encode racial biases. This is something which I think you really need to take care of. The other problem we often have is sort of how do we deal with a huge amount of variability when I build my AI models. Quite often when I talk to some PhD students in our lab, they tell me, oh, I've got this very great model. It works particularly well on this data set. But then I gave it to our clinical colleagues and it didn't work at all, correct? And of course, in this particular case, you wouldn't expect it to work. And if you go to a hospital environment, then most of the subjects will have pathology and will look perhaps like on the right-hand side and not like UK Biobank or some other data. And of course, you have lots of variability because you can do lots of types of different imaging. And you have different hardwares, manufacturers, and so on. But why do I tell you about these three problems? Well, because there's typically one solution which every AI engineer will tell you is sort of this, just get more data, correct? You get more data, all these problems disappear. And this is a very nice article in the Financial Times from probably half a year ago, where the writer here argues that in the UK, for example, if we really care about curing disease, we need to give we need to give those who have developed AI solutions access to all the healthcare data, which is out there in the NHS. And that's a pretty good idea, but in a country like, it didn't work in the UK, but also in a country like in Germany, this will just not happen, correct? Because where you can argue about whether it's the right ethical thing to do or not, but you're just not being able to convince people to do it. So, so one of the things which we've been thinking about in the last, especially since I moved to Germany, because I realized also how much more of an issue it is here, is how can we actually combine privacy with AI and machine learning? And we started doing this by, in the beginning with a colleague of mine, Georg Kaisis, who was a radiologist, sort of in the beginning to sort of, first of all, try to figure out what are the technical solutions to this, not the ethical solutions or the regulatory solutions, but what can we do from a technical point of view? Always realizing that solving this from a technical point of view is only one facet and not going to be the end game. But there are lots of different tools, federated learning, homomorphic encryption, differential privacy, and so on. And we sort of actually learn more about those, and also which of those can we really deploy in practical applications. And actually also in collaboration with Daniel Thun, we actually did some quite interesting initial studies. But I want to highlight two things which I think are quite important. So the first one is quite a lot of people will say, well, the solution to all your privacy concerns is federated learning. Just use federated learning, where instead of centralizing your data, you take your AI models, you send it to the hospital, you update it locally, you send it back, and then you can sort of iterate on this, and you can do this as many times as you want, and in parallel, and so on. And this is a solution, but I don't think it really is. And this is an article which we wrote together with some colleagues in the ethics area in Munich, sort of looking at this. And in my mind, federated learning is a great way of sort of dealing with a data governance issue, because you have control over where your data is flowing, but it doesn't really equate to privacy. So what we then sort of try to do is sort of, why do we care about privacy in the context of AI? Because we have all these possible attacks I can do on my AI model. I can do membership inference. Was this particular subject used in training? Can I reconstruct my training data using a model inversion attack? And it turns out that actually some of this is actually surprisingly easy. So this is a paper where we tried to do this. We trained an AI model using these type of images, and then try to invert the training data from the trained AI model. And you see that the images don't look perfect, but you can still recognize the most salient features. For example, the top patient there on the left-hand side had a mastectomy, correct? And you can immediately see that. And that might be a sort of a really severe privacy breach. So how can we, and this, I cannot stop this with federated learning because I'm only doing this attack on a trained AI model, correct? Only when you give me, you publish your weights and I can sort of reconstruct this from the weights. So how do we deal with this? So one possible way of dealing with this is to use something called differential privacy. And I just want to very briefly explain you the concept of this because not everybody might know this comes originally from the database world. And you can, I always sort of try to sort of explain it with some coin flips. And this is a bit outdated now with a US presidential election. And the scenario is that I might want to ask all of who you voted for. If you, let's assume you could vote in the US election. Some of you might be able to vote in the US election. Would you have voted for Trump or Kamala Harris? Now, I can understand some hesitation if you don't want to tell me the real answer, at least, perhaps at least for one type of answer. So let's assume we do the following. We have a scenario where each of you flips a coin. And you don't tell me the outcome of that coin flip, but we have the following arrangement. If the coin comes up head first, you answer truthfully. And if it comes tails first, you do a second coin flip. And again, I can't see the result of that second coin flip. And based on this second coin flip, with head you say Kamala Harris, with tails you say Donald Trump, correct? So what I now observe, what I can measure, is a combination of the true signal, which is sort of the top branch of this flow chart, and effectively some random noise, right? Now, why is this interesting? Well, first of all, obviously, depending on the proportion of true signal and noise, I can still do some inference based on this. I can still perhaps calculate if I do this many times, and actually the US Census uses techniques like this, who the majority of people in the room have voted for. And if I would, for example, say you have voted for Donald Trump, you always can say, well, actually, I didn't vote for Donald Trump. It was a coin flip which forced me to give that as an answer, correct? So you always have this idea of plausible deniability that I don't really can tie you down that you really voted for Donald Trump, even if I might have my suspicions. Actually, I don't have that suspicion, but nevertheless. And actually, this type of algorithm is very easy to implement. I don't really want to go too much into the details. You just have to do some, if you do differentially private stochastic gradient descent, just add 2 more lines effectively, which clip the gradient and add some noise to your gradient. And then you have something which is differentially private. And the results are quite significant. If I show you the same reconstruction attack, which I showed you before on a model which has been trained with this differential privacy during the model construction, I end up with reconstructions which look like this. So you probably hopefully can agree with me that none of these reconstructions are very useful and don't convey any information about what was used in the training. Now, you might argue sort of, why doesn't everybody do this differential privacy? It seems completely obvious that this works. You also have very strong mathematical guarantees, and you can sort of look up on proofs that actually this really holds. Why doesn't everybody do it? Well, first of all, some people do it very frequently, like Google. But most people will say, well, you know what, I really don't like doing this because this also makes my model worse. And you end up with this idea sort of that actually your model performance, which is shown here in this green area here, as a function of how strongly you penalize privacy, you see that actually if I have very strong privacy guarantees, i.e. very small privacy budget, then my model performance is actually quite bad. And that's effectively, you can sort of think about this, is you're adding a lot of noise to the training. That makes the training very hard. And as a result, because you have added a lot of noise, you have a lot of guarantees, but also very poor model. But in this paper, we also show that actually people, if you even add very, very large, or if you make your privacy budgets, this epsilon, very, very large, that means you have not so strong privacy guarantees. You still get very secure reconstructions. That means that even if you use a very high epsilon value for this differential privacy, you get a lot of guarantees or practical guarantees about how good your model is protected against reconstructions. And that means if you choose your epsilon correctly, you have a good combination of a lot of model utility. So your model is almost as good as a one without differential privacy, and you still have a lot of privacy guarantees. So I'm going to come to the end. And I just wanted to show you what I sort of think about the next couple of years, what will happen and what's already happened. Actually, most of it is already outdated because things have moved so fast. So what are the three key things which I think everybody at the moment in AI in medicine is talking about? Well, one thing is, of course, we've completely shifted from convolutional architectures to this transformer architectures, which have a lot of advantages because they can much more easily integrate different modalities, images and text, for example. We have switched from the idea that we always need a human annotator, for example, a radiologist or a clinical expert to annotate our data, to actually doing annotations on small data sets, but using very, very large data sets with self-supervised learning as pre-training. And of course, we sort of switched towards models which can actually not only solve one particular task, but lots of different tasks in one go. And I think that's very important. So you see, for example, here in this diagram, if you, for example, think about a large language model, it can solve a huge number of problems in medicine without being designed for one particular purpose in mind. Just wanted to highlight, and I'm not going to dwell too much into on that there's still a lot of open problems about LLMs in medicine. For example, we recently did a benchmarking exercise of LLMs, and we found there are lots of problems. For example, your LLMs are quite often sensitive to the order of information. For example, if you say the patient has high blood pressure and is diabetic, you get a different answer to the patient is diabetic and has high blood pressure. And of course, that makes no sense whatsoever. The order of information shouldn't really play a big role in this. But I'll leave you with one last example, which I wanted to show you sort of what we have tried to do in this space is an idea to take a generalist LLM and then train it with what we would call perhaps a curriculum for a specific task. In this particular case, it's referring patients which have age-related macular degeneration, and you have these optical coherence tomography images of the eye. And what we want to do is we want to train the model in an automated way to actually do a variety of tasks. So what we do is we've taken a lot of images where we have generated question-answer pairs, and these question-answer pairs are generated automatically. So they're not actually human curated, but they are generated automatically from tabular reports, which we have for the images. And then we can also enrich this curriculum with a small number of very carefully annotated images. We only have 330 images for which an ophthalmologist has written a very detailed report. And once we have sort of trained this model with both of these types of data, we can now sort of use the model in a very versatile fashion. We can, for example, say is what biomarkers are present in the image and what is the overall stage of the disease in the left-hand side, or describe what you see in the image, or here are the criteria for referring the patient to a specialist. Or write a referral letter for that particular patient, correct? And I think the clinicians find this very, very intuitive to interact with because it's largely text-based. And it's also more explainable because you can, for example, now link particular phrases or expressions in the text to particular features in the images. So with that, I really want to sort of come to the conclusion and convince you that if you use these type of tools, you will make your radiologists very happy because they sit very happily smiling there in the pub after work, and now their work is much easier. But you also see the bias problem, correct? It's an entirely male population which is sitting there. And so there's a lot of new things, I think, or a lot of open problems we have to work with. And I just want to acknowledge at the end also all the people who sort of funded our research and would be very happy to answer any questions if you have any questions. Thank you very much.